We are here today at El Rio Community Health Center. They serve about 100,000 patients in Tucson. And we are here, this is the Manning House. Supposedly they have ghosts, but we are not here for the ghosts. We are here to interview Linda Beauchasne. She's the medical informatics manager here, and we will be talking about electronic health records today. Linda, you're the medical informatics manager.
I am.
So, and I read on the website that there are more than 100,000 people being served here. So I'm assuming that's a lot of medical records.
That is a lot of medical records.
Can you tell us a little bit about how many records, what kind of information you store, and maybe what your role is? How many people work on these things?
Sure. So in about a year, we probably have 380,000 patient encounters, and that would be 100,000 patients, 3.8 visits per person. And I can break that down a little bit for you. We have about 35% of our patients are children, 0 to 17, and 54% or so are 18 to 64, and the rest are 65 and over. I supervise in the IT department 7 medical informatics analysts, and those are people who are experienced in SQL and other programming languages, and our job is to create reports for anybody in the organization, mostly senior leaders, from anywhere from the CEO to department managers, and anybody who needs data that they can't get out of the electronic health record themselves. So what's in the records? Anything from your standard patient demographics, name, address, phone number, cell phone number, email address, to preferred language, and the reason we collect that is because we may need to use translation services for someone whose language isn't English or Spanish, and race and ethnicity for reporting. And then from there we go right into the clinical electronic health record, and everything you could possibly need to know about anybody clinically, from the reason that they're there for the visit that day to their problems, their diagnosis codes, and anything clinical that is related to whatever they're here for: medical, dental, behavioral health, physical therapy.
To all the encounters, everything is recorded.
Everything is there, and it's all in one big database.
And so, over the years that you've been here, have the records changed? We know about meaningful use, for example. So how did that affect your role and the records themselves, and what needed to be done?
So, I mean, many years ago, it was about encounters, and the patients would come in and you would record their encounters, and it was all about how many encounters a patient had. But
is that before we started talking about meaningful use,
yeah,
or was that the first phase?
It was before. It was, everything was about how many fee for service. You would get paid for how many services you did. But as meaningful use came along, we've been on a journey to improve patient care. And meaningful use gave us money to upgrade our EHR, which we have.
How did that work? Did they give you a lump sum of money, or?
So it's about the provider. We are Medicaid meaningful use, not Medicare. So we actually attest to our state Medicaid agency, and we attest one provider at a time. We're a large group, but you still have to attest for each provider, and they have to pass their meaningful use objectives individually. And for every provider that attests, you get a certain amount of money. We've made an agreement with our providers that it's actually the provider who's getting the money. But
so who is the provider? What do you mean by the provider?
So a provider can be a medical doctor,
okay,
a doctor of osteopathy.
And they're all part of the El Rio network?
They are. They're all employees.
Okay.
Nurse practitioners can also attest. So the provider has to meet all of their objectives, their must-pass objectives, and then they also have to attest to clinical quality measures. So in order to meet those must-pass objectives, they have to follow certain workflows in the EHR, check the right check boxes, click the right radio buttons, and meet certain requirements to pass those meaningful use objectives. The IT department, which is, we have our technical people, our support techs who do hardware, but we also have our IT analysts and our clinical trainers who help make sure the providers, the doctors are, and the dentists, because dentists can also attest to meaningful use, are following the workflows that will fill in the right fields that will eventually report out at the end to see if they've met the objectives. So and actually it's not just the providers, it's their medical assistants or their LPNs or RNs. Anybody who touches that record can help to meet the meaningful use objectives.
And how did these change then over the years, these objectives?
So there were objectives in the beginning that were just process measures, which means did you do something? Did you give the patient some patient education? So it was just, did you do something? But as we go on now, it's being geared more towards, did you do something to make the patient better? So the quality measures are becoming much more important. And as we go into meaningful use stage 3, it's all about interoperability. Can your electronic health record send information to the patient? And eventually it's going to be, can it send information to other electronic health records or other entities like a health information exchange, or in our case, the Arizona immunization registry. So it's becoming more about talking to other health entities.
And that's where we are now, phase 3?
That's where we are now.
Is there a phase 4 coming?
No, because 2021 will be the end of Medicaid meaningful use. And
so what's next? Are we done?
I don't know the answer to that. I'm sure they'll come up with something else, because it's all about incentives to encourage providers to just keep getting better and better.
So a couple of things that we also discuss in our courses, for example, controlled vocabularies that are being used.
Mm-hmm.
And one of the ones that changed, that had a big change, was ICD-9 to ICD-10.
Yes.
Was that a headache for you?
So the interesting thing is that the United States was about 30 years behind the rest of the world with using ICD-9, because the rest of the world had gone to ICD-10 long before we did. We thought it was going to be a huge change. So, and we were afraid of that. So about a year before, maybe a little bit more than a year before the 2014 deadline, we got an interdisciplinary group together, and we had regular meetings. We looked at what the requirements were, and we were actually ready to go in 2014. But the government said, well, some EHRs aren't ready, and we're going to put it off another year. So it had already been a really long delay. So we were actually very disappointed that they put it off a year, and it was put off till October 1st, 2015. What happened to us is we lost our momentum, and that was pretty scary, because we were so ready to go that we weren't sure we were going to be ready to go when the real deadline came up. But we got our group back together. Our EHR was ready, and so October 1st, 2015 was the cutover. We had to upgrade our EHR to be ready.
So what did that involve? I'm assuming that people had to learn about new codes,
Yeah,
and then
so
you had to have them in a database?
Yes, so there's two things. We had to have the database updated, and we update our codes on a regular basis, because there's
How many
always
codes are there?
Oh, thousands of codes. We don't use all of those codes, but they're available. And then we have certified professional coders who actually review, once an encounter is prepared by a doctor and they finalize it, it goes to the coding department and they'll review those, and a professional coder can query the doctor and say, I see you've used this code, is this what you really meant? Or they'll just verify that everything is correct. So all of our certified professional coders had to get certified in ICD-10. So they went through all the training, got certified, and then the cutover date, we turned off the ICD-9s, they have an end date, turned on the ICD-10s, they had a start date. And it went pretty well. There were some holdovers that even the software didn't catch. So there were some corrections that had to be made, but it was about as, it was the same thing as the Y2K, that everybody thought everything was going to blow up and it didn't. And, there were a few.
Luckily.
Yes, luckily for us, we didn't have a huge thing, but we were very prepared. We had gone through everything and made sure that we knew what was going to happen. And I mean, being prepared was the biggest thing that helped.
So now that we have all these new devices and people wanting their information, how do you deal with that? How do you give people information? I'm assuming there is some kind of patient portal. And could I, for example, if I have a Fitbit or a smart scale, would you accept my information? Would that be used here? Is that anything like that going on?
So there is a patient portal. Any patient can log into the patient portal. They have to get their own account, and if it's a parent, they can put their children on their account, and they'll see their encounters, their lab results, any documents that the provider can send. So if you leave an appointment and you get what's called your patient plan, this is what I want you to do, this is what we did today, and there might be some instructions on that. You can have that sent to the portal instead, so paperless, so to speak. So we're trying to enroll more and more people in the portal for several reasons. One, it's a meaningful use objective to get people to use the portal for bidirectional messaging. So if you send a message to your provider team, somebody responds to you, or if you can request an appointment through the portal or make an appointment through the portal, that's considered bidirectional messaging. We'd like to get rid of the paper. Papers get lost. So we want people to use the portal.
And can people give you information?
So we're starting a pilot very soon that will be what we call wearables, we're trying to get Fitbit type of devices. I don't know that Fitbits are as popular as they used to be, but one of the things we're going to be looking at is at-home monitors. So blood pressure monitors for people with hypertension, glucose monitors for diabetics, and those would be interfaced with the EHR rather than, so maybe with a wireless connection, rather than bringing your device in and having it loaded into the system where we would have a direct connect. And most of the EHRs now are using APIs so that the device can write directly to the EHR database. And this is where we're going now, is with application programming interfaces.
Would you say you're ahead of the curve in comparison to other hospitals, or about the same, or?
I think we're a little bit ahead. I think that we like to try new things here.
Okay.
So we're always trying to innovate.
So most hospitals are not doing this yet?
I don't think so. Not that I've heard of. And we try to be a little bit ahead of the curve here. We're our downtown Health on Broadway clinic, which is right in the middle of downtown. We try to innovate there. It's our little hub for innovation. So anything new, we started with kiosks there first. So we have kiosks to check in with, and we have tablets. They're either an iPad or a Surface Pro where you can fill out, you can either check in and they also do questionnaires. So screening tools, and we'll try it out there first and then spread it to other clinics once we've done the proof of concept.
Are there any problems you've encountered that you never expected you would see with electronic health records? Maybe not even related to the technology, but to the people using it, or?
Well, change is hard. So anytime we introduce anything new, it doesn't matter if it's something that's good, anytime it's a change.
And do you make changes for individual specialties, or do they all have the same type of interface?
Well, I mean, the interface is the same, but we do have special, what we call templates. That's the user interface. We have a specialty for our HIV program, and they use totally different templates than, say, internal medicine or family practice. And our pediatricians definitely use different templates than our adult medicine. So they sometimes will use the same templates across all specialties, and if we say, like say if you're going to do a referral, and you need to refer your patient out to some specialist, the referral template would be the same across all specialties. So we're going to make a change to the referral template that the organization wanted, senior leadership says yes, and then we notify everybody of the change, and it may be 2 or 3 fields that are different. And then everybody says, why did you change my template? So change is hard no matter what it is, even if it's for the good of the organization, and it's going to be, how many clicks is that? Do I have to do 3 more clicks to get there? Yeah. So everything is, you have to communicate ahead of time, explain why, and hopefully the change will be accepted as a good reason.
And would you say that your practitioners, your clinicians, have accepted electronic health records well? Because one of the big complaints is, you lose that patient time, the interaction with the patient, because you're typing on the computer.
So here's an innovation that we've brought on in the last, I'd say, year and a half, is scribes. So a lot of our providers...
So not technical innovation?
Well...
People scribes?
It's technical in a way, because it depends. So we have people scribes, that's an actual person who goes into the room with the provider, and they will have a laptop, and the scribe will be sitting off to the side. Patient has to agree that, yeah, this extra person is in there, and I don't know of any cases where they haven't. So the scribe will record as the provider, the doctor is dictating. They're like a personal dictation machine, and will record the record, and then the provider will review the dictation later, and then the record is as though the doctor was doing the recording, but the doctor is face-to-face with the patient.
Yep.
So that's the personal scribe in the room. But the other thing we're doing is virtual scribes. So the virtual scribe is actually an iPad on a long pole that's kind of like an IV pole that can be rolled around in the room, and they're actually out of state. So it's just a wireless connection, and you can see the person's face on the iPad.
Also, there is a person on the other side?
There's a person on the other side.
It's not voice recognition?
Nope, the person's on the other side, and they're actually there. You see their face on the iPad, and they're introduced to the patient, and then you kind of can move the iPad and off to the side. And I've actually been in one of those visits, and you totally forget that the person is there. The doctor is face-to-face with you. They're dictating out loud because the scribe has to hear what they're saying, but you totally forget that the scribe is in the virtual scribe is in the room, and the doctors love having that. And apparently it's cost-effective because we've gotten quite a few more of those, and the doctors don't spend their time documenting, so they get that time back, and they get the face-to-face personal bedside manners with the patient.
Very interesting. I'm certainly happy that you were willing to let us interview you, and thank you very much.
My pleasure.